First, good afternoon, everybody. Thank you so much for joining us today during your lunch hour for CAFP's second End of Life Option Act webinar, What You Need to Know on June 9th. Today, we have three wonderful speakers joining us. We have Leah Newkirk, CAFP's Vice President of Health Policy, and two CAFP family physician members, Dr. Catherine Forrest and Dr. Tarek Mahdi. Leah, as many of you know, does a lot of the policy work for CAFP, and that often includes reviewing proposal legislation and commenting on behalf of our organization and on behalf of our members, and was involved in a lot of the education work we have put out on this act since its passing. Dr. Catherine Forrest is part of the Stanford Health Center as of 2013 as the acting chief of Stanford Family Medicine. She is also the medical director of Stanford Health Center at Los Altos, and previously taught at in the Cutting Edge Pisces program in the Department of Family Medicine, Family and Community Medicine at UCSF. Dr. Mahdi is a board certified in family medicine and in hospice and palliative medicine, and is a very active member of the Riverside and Corona communities. He is the medical director of several nursing homes in Riverside, as well as the Gero Palliative Program at Parkview Hospital, and among a list of many other activities he engages in, he also sits on the CAFP's Medical Practice Affairs Committee to provide us with some direct commentary on pressing issues. Again, thank you so much for joining us today. A note about questions for the presentation. You're free to type them into the chat box, which you should have access to at the top of your screen, and we will do our best to address all of them at the end of this presentation. And as usual, the slides will be sent out either by the end of today or by tomorrow. Thank you. Leah?
Thanks, Sonia. This is Leah Newkirk. Again, I'm the Vice President of Health Policy at CAFP, and my role in this webinar is to give you a summary of the law itself, the End of Life Option Act. Next slide, please. So this law went into effect exactly a week ago on June 9th, and it authorizes a terminally ill adult, that's a person who is 18 years or older, who meets specific qualifications, which I'll go through, to request and receive a drug for the purpose of ending his or her life. Next slide, please. CAFP took a neutral position on this law when it was a bill, but now that it is law, we are strongly interested in providing you with education about the law. It's important to know that whether you're interested or willing to participate and prescribe aid in dying drugs, or you're not, the law governs your behavior. So every member of CAFP should understand what's in this law. We also see this as an important opportunity to highlight the role of family physicians in end-of-life care generally. So there's significant interest in seeing primary care practices integrate palliative care and advanced care planning, and CAFP hopes to be a source of support as you think about your end-of-life care, the services you provide more generally. Next slide, please. So who is a qualified patient? Who can make the request? The individual must be terminally ill, and that is defined in the law as an incurable and irreversible disease that will, within reasonable medical judgment, result in death within 6 months. The person must voluntarily make a request for a prescription for an aid in dying drug, be a resident of California, and and must be able to establish residency. Must document his or her request in a specified form. And I'll note that the California Department of Public Health now has all of the forms that I'll discuss on their website, and I'll ask Sonia to distribute a link to that page when she sends the slides to everyone. So must document that request and must have the physical and mental ability to ingest the aid in drying drug without assistance. Next slide, please. Now, important when you're thinking about the workflow here, the patient seeking an aid in drying drug must make 2 oral requests at a minimum of 15 days apart and submit that written request in the specified form directly to the attending physician. The written request must be signed and dated by 2 witnesses. Only one witness can be related to the patient, and only one witness can be staff or otherwise employed by the practice of the attending physician. Next slide. There are 2 roles for physicians in the process. The primary role is the attending physician, and this is defined in the law as the physician who has primary responsibility for the health care of the individual and treatment of the individual's terminal disease. And we've been advised that that "and" is significant. So think about that language and make sure you qualify. The consulting physician is a physician who is independent from the attending, can't be in the same group, and who is qualified by specialty or experience to make a professional diagnosis and prognosis regarding the terminal disease. So pretty broad definition that family physicians are likely to fit into there. Next slide. Now I'm going to walk you through the procedures. This is a very prescriptive law, understandably, and it lays out a number of steps that patients and physicians must take. And again, this slide set is a good starting point. I recommend that you also look at the Family Physician's Guide to the End of Life Option Act that's available on our website. It has even more detail on all of these steps. But we'll walk through them now. Next slide, please. So the first step is to consider whether the patient is qualified. Well, the first step is the patient has made that first oral request, and the attending physician must consider whether the patient is qualified, whether they can make medical decisions, whether they're terminally ill, voluntarily making the request, and if there are indications of a mental disorder, the physician must refer the individual to a mental health specialist, and that's defined in the law as a psychologist or psychiatrist for an assessment. Now, it's important that the attending physician confirms that voluntary request, that the patient is not coerced or under undue influence, and the law requires the attending to have a conversation with the patient outside of the presence of others, except an interpreter as necessary. Next step. And then there's counseling in this initial phase. And again, these are not casual recommendations from CAFP, but specific topics that you have to cover to comply with the law. You have to inform the patient of his or her medical diagnosis and prognosis, the potential risks associated with ingesting the drug, and the probable results of ingesting the drug. You have to inform the patient now and at several other moments that he or she can obtain the drug but not take it, that he or she can always change his or her mind. And inform the patient about feasible alternatives or additional treatment options, including comfort care, hospice care, palliative care, and pain control. At some point, again, you need to give the written request to the patient and go through that with them, and they need to complete that and submit that to you as an attending. Consider whether you want to give it to them at this earlier stage so they have time to think about it and go through it. But at some point, give that form to the patient to make that written request. Next slide, please. Step 3 is the referral to the consulting physician. The consulting physician must examine the patient and medical records and confirm the diagnosis and prognosis, the capacity to make medical decisions, and that the patient is acting voluntarily. Again, if there's indication of a mental disorder, the consulting physician must also refer to a mental health specialist for an assessment. The consulting physician has to document his or her findings and complete a consulting physician compliance form that's also available on the Department of Public Health site, and submit that form to the attending physician. Next slide. So again, consider that the patient has to make 2 oral requests, a minimum of 15 days apart. So in your sort of second stage with the patient, you can counsel the patient, you must counsel the patient about having another person present when he or she ingests the drug, not ingesting in a public place, notifying the next of kin, and it's noteworthy that if the patient refuses to notify the next of kin or is unable to, that doesn't disqualify them, but you have to inform them, counsel them on notifying. Counsel the patient on participating in a hospice program and on maintaining the drug in a safe location. Next slide, please. Now, the attending physician, before he or she prescribes the drug, must once again offer the patient the opportunity to withdraw or rescind the request. At this final stage, the attending physician must provide the patient with another form. It's the final attestation that the patient is supposed to complete within 48 hours prior to self-administering the aid in dying drug. So the attending physician should counsel on that form. And then the physician can prescribe the aid in dying drug. You can't hand the patient a script. Physicians who qualify can dispense directly to the patient or must deliver the prescription to the pharmacist. Next slide. And the final step is documenting and reporting, and there's lots of requirements here. The medical record must document those 2 oral requests, and you must have that written form. The attending and consulting physician's diagnosis and prognosis, determination of capacity to make medical decisions, and determination that the patient is acting voluntarily and has made an informed decision. The medical record must document any mental health specialist assessment if performed. It's not necessary, but if it's performed, it should be in there. The attending physician's offer, note that you made that final offer to the patient to withdraw or rescind his or her request at the time of the second oral request, and a note by the attending physician indicating that all requirements have been met, and a notation of the aid in dying drug prescribed, as well as that final attestation form from the patient. Next slide. Within 30 days of writing the prescription, the attending physician must submit all of these forms, or all but one, to the California Department of Public Health, a copy of the written request, the attending physician's checklist and compliance form, and the consulting physician compliance form. And within 30 days following the patient's death from either the drug or any other cause, the attending physician must submit a attending physician follow-up form. Next slide. The law provides broad protections for physicians who participate, from civil or criminal liability, censure, discipline, suspension, loss of license, loss of privileges. The law explicitly prohibits any contract, will, or agreement from being conditioned upon or affected by a request for an aid in buying drugs. So, for example, we've received the question, does this affect life insurance? And it cannot. The law also protects people who are present or who help prepare the aid in dying drug, but they cannot assist the patient with ingesting the drug. The law does not protect for that. Next slide. On the other side, the law protects providers who opt out of participating, and they can not participate. They can also not inform a patient regarding his or her rights under the law, and they can refuse to refer an individual to a physician who participates in activities authorized under the law. So a physician can basically say nothing about the law, and they are protected by the law. And you are protected, but CAFP encourages family physicians, of course, to have a full conversation with patients about options available. And you should consider, if you're opting out in advance, how to handle a request and how to assist the patient who is struggling with issues at the end of life. Next slide. Now, health systems, as many of you know, systems and other provider employers, groups can prohibit their employees and contractors, including other healthcare providers, from participating. So, for example, the Catholic healthcare systems are prohibiting the physicians who work for them from participating. The prohibiting provider must first give notice of this policy, and if the provider fails to provide notice, he or she cannot enforce the policy. Now, it's noteworthy that the system cannot prohibit you from diagnosing, giving a diagnosis, prognosis, or determining the capacity to make medical decisions, and cannot prohibit you from providing information on the act or providing a referral for the purposes of participating in the act. Next slide, please. The prohibiting healthcare provider can take action. You can lose privileges, be fired against any individual who violates their prohibition. Not against a person who provides information, but a person who participates in a system that is prohibiting participation. Next slide, please. And again, we encourage you to visit our website. I mentioned we have a guide, a family physician's guide to the End of Life Option Act, which gives you the details contained in these slides and more. It's a great starting point as you think about your process with this law, and other resources on end-of-life care generally. So please do visit our website, familydocs.org/EOL. Next slide, and I think I'm passing it along to Dr. Forrest.
Hi, so we're going to talk a little bit about the things that you might run up against in trying to implement in your institution, largely in institutions, and then a little bit later, we'll be talking a little bit about if you're on your own or in smaller practice. So let's go ahead, go next slide. I think the first thing that will happen is not dissimilar to what happens now, is that a patient may come to you and ask for the end of some medication aid in dying. And actually, the very first thing as either an opt-in or an opt-out physician to do is actually respond with a clarifying of the request. And that means to really see if you can assess the root causes underlying their request. We know from the experiences in the other states that have enacted this law that most people that are seeking this option of medical aid in dying may have other concerns that you may be able to address and should address. So the very first things are to affirm your commitment to care for the patient and his or her loved ones, and then get to address the root causes of the request. So you may consider addressing the therapeutic alternatives as well as aid in dying. If you've thought your own underlying opinion about this and you feel that you're not opting in, you can consider whether or not you can have a conversation with your patient about referral, but certainly you can discuss the therapeutic alternatives, and then you can consult with colleagues. Like anything new that in practice, you may feel discomfort. All of us felt discomfort when we first did anything, the first blood draw, the first surgery. So it's not unusual to feel discomfort at the first time someone asks for this procedure or this medication or this way of dealing with an end-of-life option. So if you're uncomfortable, that is a normal physician experience. We know this from our colleagues in the other states. It's a good time to consult with colleagues and to pull together. And then you're going to provide care or you're going to refer the patient as appropriate. And in some cases, in an opt-out environment, as Leah noted, we are at the CAFP encouraging people to be open about the law if they can, but some people, for some reason, will decide that's not within their construct of how they practice, and that will be the way that it is for their patients. But they will have been the patients will have been notified ahead of time. Next slide. So in a caring conversation, what we're talking about here at the end of life for every human who's in this terminal situation is we're switching from cure to care. And the model, instead of telling patients what the options are, asking them what they want, and then telling them how it's going to work, we really are looking for this other model, this ask, tell, ask. So start with ask, what do you understand about your situation? What are you hoping for? What is the most important things to you in the time that you have? Really inquiry. What is it that is happening for you as an individual? And then you're going to tell them about what the options are. You're going to tell them things they may not know about their options. For instance, palliative care or hospice or other things about medication aid in dying, for instance. And then you're going to ask again, what can we do to best help you live the life that you want to live in the time that you have? So for instance, if somebody told you what they were hoping for was to feel healthy enough to travel to their child's graduation, that's a really different conversation and then they're done. That's a different conversation than somebody who is really hoping that they don't have a time period in their life when they're having repeated seizures and very sedated. So you can see how asking and really understanding someone's what's happening for them becomes so very important. Next slide. In this situation for implementation, one of the things that keeps coming up in California is what are the options available to you in your area? For instance, palliative care, where can you refer? Is it insurance dependent? For hospice care, is it at home, hospice care at home? Are there residential hospices available to you? For physician aid in dying or medical aid in dying, who is involved? What does it involve? Is there a combination of things where someone may be interested in palliative care because of some goal that they have, but then ultimately they're interested in hospice care? Or if it gets to a certain circumstance, they change their mind and they are interested in medical aid in dying. So you're really interested in what are the options, and also what are the options where you are, because they may be different, and this becomes important. Next slide. So for a physician within an institution, what are the next steps for legitimate requests for medical aid in dying? Well, it turns out that the institutional policies are starting to roll out and for implementation of these laws. And above the requirements of the law, as Leah pointed out, it's a very prescriptive law. The next questions for us really are there any additional requirements that are being placed by an institution? And in different areas, there may be. There may be, for instance, at UC San Francisco, they added a requirement for a psychological evaluation. So you want to know, is there a policy? And then is there any additional requirements above and beyond the law that's required? Some hospitals say that they're opt-out, but that's only for hospital physicians, and that the hospital, people that are affiliated to the hospital, are actually under the purview of another policy, which is the one that technically they work for if they're in an institution. So make appropriate inquiries within your institution. Who, if you are a salaried physician, or who actually gives you your privileges, and then who are you, whose policies do you follow in the different settings? For the most part, these are ambulatory. If it's a physician aid in dying or medical aid in dying, it's an ambulatory medication. It cannot be taken in a public place. For the most part, it's not taken in a hospital. It's ambulatory. So who governs you in your ambulatory site? If you're looking at who you are, and again, people may decide this on a case-by-case basis. It may shift or change over time. But if you're, for a particular patient or a situation, or for right now, finding that you're unwilling to participate, consider whether or not you might be willing to refer within your network. This is not dissimilar to other procedures that we already do not engage in. You just, for whatever reason, it's not right for you, or you don't do that, but you're willing to refer a patient elsewhere. See if you could get that information. If you're not, that is what it is. But if you are, consider a referral within network. And if you're willing to provide care, then we're going to talk a little bit more about resources if needed. How can you increase your own skill? If you're going to provide this service, do so with excellence in care, the same way you would do anything for your patients, is to do so with excellence, compassion, and care. Next slide. So here are these questions that you might ask your institution. Does your institution have additional requirements? For instance, required consults or oversight. For instance, in my particular institution, the consulting physician must be in palliative care. It's a requirement in my institution. That would never fly in some of my sister institutions that don't have palliative care department even. So that would never fly. But see, you can consider and ask. Find out if there are additional requirements. For the most part, there are no additional requirements that we know of for many. For instance, Kaiser has no additional requirements in Northern California. Second question, what are your institution's policies surrounding medical tourism? What that means is people coming into your institution solely for the purpose of getting access to physician aid in dying or medical aid in dying. We expect we'll see some of this since there's federal dollars cannot be used for medical aid in dying. Similarly, some of the institutions, particularly those that have under the Catholic diocese, are opting out. So patients can't have access if their institutions of their doctors prohibit the physicians from participating. We expect that there may be some movement. So find out about what are the policies of your own institution if it's opt-in surrounding medical and tourism, and also what would you plan to do to help if your patients wanted access and you're in an opt-out institution. There's some experience in Washington and Oregon for how patients can be referred, and resources for that are a little bit later in this presentation. But find out what your institutions are. By the way, you have to be a California resident to participate. That was pointed out earlier. You can't come into California without establishing residency. Who maintains the current roster of willing physicians in your area? Is the medical society doing that? Is there just an organization informally doing that? Again, can you find out amongst yourself who are willing? And also what institutions have opted out, as we talked about. Another area that's turning out just as in startup is what pharmacies might be participating in order, if you write a prescription or a physician writes a prescription, where can it be filled by a patient is another one. And then what medication protocols can be used. Again, there are resources available for what has been used and what can be used that's effective, and how to give patients instructions for how to do this. Next slide. So here are some resources for you. The top three are ones that are recommended by the state. There's a group that was involved in setting up these lines. The doctor-to-doctor consultation line links physicians that are in states where it's been legal for some time with physicians in our state for direct consultation for the medical practice of aid in dying. For terminally ill Californians, this phone line has been set up just to get information about the law. It's not an advocacy line, it's just for information about the law. There's a pharmacist-to-pharmacist law from the endoflifeoption.org. That's also from the organization that supports the law in Washington and Oregon, and for access for pharmacists. And the last one that looks like I put too much, there's too big a space, but you can see the Death with Dignity provider site is from the international site, who has the most information specifically about medical protocols. So which medications and how. And there has been some national concern about the initial protocols that were using Seconal when the price went up fairly dramatically. That was related to some political and economic forces that increased the price to be somewhat prohibitive for patients who don't have insurance costs covered. So there are alternatives that have been developed by pharmacists and physicians in the states where this has been legal for some time, and those are maintained by the national organizations, largely Death with Dignity, but also by the organizations that support the Death with Dignity law in Washington, as well as in Oregon. So that last link there can also provide information. In my experience, in our experience in Northern California, establishing how to link physicians, willing physicians with pharmacists and the exact protocols has been a challenge, and these organizations have been extremely helpful. Next slide. I've given my email here. I'm happy to field questions for people about specific implementation questions. I have emphasized in my own organization the importance of education for the purposes of our patients' care, and that includes the many physicians who are opting out themselves, as well as those that are opting in for the purposes of supporting end-of-life options, plural. How can we best attend to our patients' needs at the end of their life? And I want to reiterate the excellence of the CAFP's website in providing lists of other resources that are too numerous to put on our webinar, but there's many resources of articles, podcasts, and other sites that can be hugely beneficial when you're seeking to implement the law. Thank you.
Thank you, Dr. Forrest. Dr. Mahdi, are you ready?
Right. Hi, everybody. This is Tarek Mahdi. I'm a family physician down here in Riverside. And basically, if you could have the next slide, please, is to talk a little bit as a role of a family physician. I'm in private practice, a small group practice. The question of patients requesting to end life is not new. As a physician, over 20, 30 years of practice, I've had this question given to me numerous times. But obviously now, as of June 9th, it is law where patients are allowed to carry it out. We could be the attending physician when this comes to the forefront. When the patient asks, we could be consulting. And I think one of the things we as physicians need to be prepared, because I think that will help us be more comfortable, is we need to know what laws protect us and how can we answer the patient's question when it comes up now in our own practice, organization, hospital. We all know that we can opt out, but provide all the necessary information and make the referrals necessary. So definitely, as previous speakers have mentioned, it's really important to know who your referral sources are so that at the time of a question, you're prepared. The other option, obviously, we can always opt out completely without providing information, which will depend on different physicians, how they feel about this new law. Next slide, please. So the question we all have to ask ourselves are we comfortable with having the patient make this choice to participate in the life option? And are we comfortable with it? And would we want to be present at the time? And if we don't, would we be willing to refer a patient or know where to refer a patient? Next slide, please. So going forward, I always say it's really important to prepare. A patient normally doesn't just pop the question, "Doc, it's time for me to end my life." It's usually a process going downhill. And I always like to be more proactive. Before the patient pops the question, if a patient has a chronic terminal illness, start the conversation early with them. Evaluate and understand their wishes at the end of life. The PULSE, the Physician Orders for Life-Sustaining Treatment program, is an excellent form that helps us initially start understanding our patients with a life expectancy of, say, a year or less. And evaluating what is patients' wishes are, what is important to them in life and what is not, so that when the question is popped, we are prepared. And hopefully we are able to address all patients concerned early on so that that question is not asked, that we are able to fulfill all their complaints and manage all their symptoms. As mentioned earlier, the question to end life is always, I think, in my perspective, is a result of some form of symptom that is not being well managed in the patient, whether it's physical symptoms, psychological symptoms occurring at home, and those need to be addressed. And even as a physician on our own, is very hard sometimes to find out exactly what's happening, and having a team approach, a palliative care program involved would always be very, very helpful to get them involved early in a chronic and terminal illness, even before hospice comes on board. Can I have next slide, please? So I think it's really important that this law is voluntary. We can always decide to opt out at a later time if being part of it does not agree with our own morals. But I think going forward, it's new. There's more to come, I think. And I think there's a lot of unanswered questions still out there. And I think with time, a lot of these questions are going to be resolved going forward. And I just want to, next slide, I think that's my last slide here, is some of the resources. It's really important is if we do decide to choose to opt out, it's really important to know who in your community is opted in and is able to provide this service. Pharmacists, definitely, it's going to be interesting to see how they participate in this new law. We already know that a lot of pharmacists have a hard time when it comes to narcotics. And then consider keeping a fact on the End of Life Option Act for patients. So if they choose to participate or not, you know, I think having mid-level professionals and staff also participate and understand what this new law is, and in servicing them is going to be important, so that the whole practice is informed on this new law as it goes forward. So we actually in our practice have not in service everybody on it yet. It's something we're looking forward to do. Next slide, please. And so you got my email down there. I'd be happy to answer any questions, or if anybody has any questions, they can email me. But I think this new law is just new, and there's more information is going to be coming down the road. But knowing your resources are going to be the most important. Thank you.
All right. Thank you, everybody. Thank you, Leah, Dr. Forrest, and Dr. Mahdi. Right now, we are ready and available for questions if anybody has any. You can just type them into the chat box, which again, I said you should be able to access at the top of your screen. While we are waiting on some questions, are there any sort of closing thoughts from any of the speakers? Any common questions you've been encountering from other physicians that you might want to go over?
This is Tarek. Maybe it just what I think is really important, and I think it's on the forefront of a lot of us today with the healthcare reform, is really the advanced care planning and starting an early discussion with our patients, especially those with terminal illnesses, early on, completing POLST, completing an advanced directives. Those are excellent documents that not only are important, but also open up the door for a conversation so that patients can ask questions, because many times they do want to ask and they never get a chance. And I think those documents are really very useful in starting the conversation early, not waiting till their symptoms are completely out of control and they'd rather opt with the physician aid in dying program. Thank you.
Thank you, Dr. Mahdi.
This is Catherine Forrest, Dr. Forrest. I think I might also add that one of the things that's been happening is in implementation at the institutional level is twofold. One is trying to put together policies themselves, finding examples of policies, instituting institutional policies, but the other is putting together mechanisms for adequate documentation, and they exist. For instance, an electronic record, which under meaningful use, many people are in electronic record, putting together adequate mechanisms to automatically do adequate documentation at the visit. So if you're in EPIC or eClinicalWorks or whatever particular form you are, to put into place a mechanism for documenting visits and the forms themselves so that they're scanned in, and then a checklist put into place. I've put together a checklist for our institution that I'm happy to share with anyone that's interested in it, that just provides the framework, and then each electronic record can they can put together the documentation for what a chart note looks like, a visit note looks like, that provides the documentation for the letter of the law, regardless of whether or not you're doing aid in dying or counseling for the other thing that we just got funding to do under Medicare, which is end-of-life planning, which ought to cover all the options: palliative care, hospice care, POLST, advanced directive, the things that are critical and desirable for our patients in the last months of their lives.
Thank you. I think one common question that we get a lot here at the CAFP is regarding payment, and specifically on payment for having the conversations in the first place and on whether the drugs are covered. If anybody can speak to that.
I can speak to the issue of payment. Payment for these visits is covered as in any other end-of-life or care. It's counseling visits. They're not unique in any way and can be billed in the usual sequence. The medications themselves, it's decided on a case-by-case basis by insurance. So, for instance, in the other states, they're often covered by insurance, but sometimes not. In California, for Medicare, Medi-Cal patients, there is a carve-out, and the medications are covered by state funds. They're not covered by Medicare. It's not covered by the VA. And the medications themselves, the compound, the cheapest compound that's being currently used in those instances in Washington costs approximately $400 for the group of medications that's compounded for use. The current price of the protocol that uses Seconal is actually quite expensive, $3,000, $4,000. And that was the initial prescriptions that were being used. But the alternatives are effective and fast and are much less expensive than that. I'd like to point out that this is a problem that we've had to deal with for other things that there's federal funding blocking for in the past. And so it's an interesting, the workarounds have been developed in the past for things where there's block for use of federal funds for. but it's still difficult. It's still a difficult thing for our patients to figure out.
Thank you. We do have a question from someone in the group. If these medications need to be compounded, does that restrict the pharmacy's availability even further?
May I answer that one as well? There are protocols that allow the prescriptions to be dispensed and can be compounded at a home setting. So the short answer is not necessarily, but we're still working on that. They're statewide, for instance. We know there are many pharmacies that are willing to participate, and since the law requires the prescriptions themselves to be either picked up in person or sent through the mail with instructions for reconstituting them, that should not be prohibitive. Similarly, we're so fortunate in that this has been worked out in other states. We're not the pioneer state. We'll see how it goes.
On that note, sort of, both you and Dr. Mahdi mentioned reaching out to pharmacists to see if they were participating or not. Do you know of any resources that have already have a list of those pharmacies, for example, or where they can go to find a list of these pharmacies, or is it something they have to kind of reach out one by one on their own?
I can let Dr. Mahdi answer the smaller areas of Southern California. But for groups, what's happening is because of the insurance groups, if you're an opt-in organization and you have, finding pharmacists within the group is a responsibility of the insurer. The groups have been finding at least one or multiple pharmacists for the group, and those are being held in the same way that the name of willing providers is held. I'm not sure, and then the pharmacist to pharmacist line that I gave you, I believe is also keeping track of or may be able to provide some assistance. But I'm not sure that there's any other list of pharmacists per se, other than finding out locally who is participating. Dr. Mahdi, are you aware?
Yeah, no, I am actually not aware. We as a group have opted out in the law, but not opted out in providing information. I think I'm not sure if there's any pharmacies or which ones would be available for it at this point. I think once, we actually don't even have a list of providers in our community who are participating. And that's going to be an interesting one, trying to figure out who is and who isn't. And so I think there's more to come down. I mean, I'm not sure who's opting in. And those would be the ones who would probably know which pharmacies they would use.
My recommendation for now would be to contact the institution that you work in, if it's a group, and if you're in a solo practice, would be to contact the doctor-to-doctor line.
Sonia, this is Leah, and I received the question, is a psych evaluation required if indicated by both the attending physician and the consulting physician, or just one of them? And my interpretation of the law is that it's required by both. If either physician determines that the patient has indications of a mental disorder. So I think it is possible for both to require separate evaluations by mental health specialists. Just wanted to see if Dr. Forrest or Dr. Mahdi has heard differently or interpreted that differently.
No, we interpreted the same, that either one can require, that the purpose of an independent consultant is for either one to require mental health consultation. And if the mental health consultation says that the person is not mentally competent to make a decision, then it may be that you can address the underlying issue, but that person is not mentally, they don't fit the letter of the law. They're not an eligible candidate under the law.
Mm-hmm.
Yeah, and it's Tarek. I think same way. I mean, I think also depression, major depression is going to be a major challenge, especially at the end of life. And so having an evaluation would be really important, especially if patients opting for this physician-assisted.
This is Leah again, and I have, my understanding is that having a mental disorder does not necessarily preclude a patient from requesting and receiving the drug, but the attending and consulting physician must make the referral and must determine, along with the mental health specialist, that the individual still has the capacity to make medical decisions and is not suffering from impaired judgment due to the mental disorder. But it does not, in and of itself, preclude the patient from receiving the aid in dying drug.
That's our interpretation at Stanford, and also the interpretation of our specialists.
Mm-hmm.
Thank you, everybody. I have one question asking, I'm part of a very large group, about over 1,500 physicians, and it sounds like the second consultant cannot be part of this large group. Is that correct? And if so, how to navigate that with insurance coverage?
We believe, based on what's that it can be a part of the group, but not part of your practice group. So if you practice in an office, they can't be your direct colleague, but it doesn't mean that they can't be part of your medical group. So for instance, if you worked, it can be within Kaiser, it could be within UC, whatever, but it can't be in your office. It can't be someone who sits next to you and that it's a direct colleague. And that's how it was interpreted, as it would be for any second opinion. The intention is second opinion with independence in that way. So that's how it's been interpreted by in Oregon and Washington, and our law is directly derived from Oregon's law. I hope that's helpful. It's not that it has to be from a different, completely different group, but from a different practice is a better way to say it.
Okay, if she has a clarification, I will be able to read it to you. One other common question that we often get is if there is a specific compound that the law specifies, specific drug the law specifies to be prescribed, or compound.
No, the law is silent on what the medication is, as always, and it is up to a physician to determine what medication they would use. And hence, there's the possibility for different compounds to be used for aid in dying.
Okay, thank you. We still have some time for a couple of questions, if anybody has any. In the meantime, Dr. Forrest, I know you had mentioned this during your talk about coming up with the model policy. A policy. Is there anywhere they can look to for model policies that could possibly help them?
I am not aware of model policies actually being published anywhere. Although I believe that there's been some generosity within organizations to share their policies. So to date, I am not aware of any repository for policies on this. But so I think that in the best resources have been actually the institution to institution within professional organizations. Mm-hmm. The CHA, some of the larger organizations. I know that the universities have been sharing. It'd be great if some independent institution would put some model policies up.
Thank you.
If I might, one of the other issues that has come up with an implementation has been training within organizations. There's a couple of good trainings that have been put up specifically to train physicians, including our own at the CAFP. But there have been webinars that have been put on by some of the larger organizations that are public. I know that Kaiser's is public now and Sutter's is public now, and those are also can be resources for smaller organizations that may not have the resources to put together physician training. They may not be specific to your own policies, but they might be a place to start.
Thank you. And in regards to training, both you and Dr. Mahdi, would you be able to comment on who should be trained? Everybody in the office, from staff at the front desk to physicians and physician assistants. Can either of you speak on that?
Tarek, yeah, I'll be happy to talk about it. I think so. I think everybody should be educated about the law. We spend some time with our patients, but our patients spend more time with our patient care coordinators or medical assistants and some of our mid-level support team. And so at least having them know the law or know it exists, we don't expect them to be consulting them about it, but at least knowing it so that they can alert us if a question like this comes up so that we can address it if a patient doesn't bring it up themselves. So we do intend to educate all our staff in our small group. And just in addition, our local organizations like Riverside County Medical Association has put out several seminars on this new law that quite a few physicians have attended. So I would say just look into your local community, and I'm sure there's going to be quite a few resources out there giving these seminars.
We have just done some training for full staff, partly because any staff member can opt out, so they can. It's not just the physicians, but a medical assistant or a nurse may not want to participate in any of the pieces of it. There's faxing forms, and there's many different pieces of it that we want to honor any employee their interpretation, their conscience in this. So we've done general training on what the law is, and that any individual has a right to not participate for a particular patient, but also on the flip side, our commitment to not abandoning our patients at the end of their lives, and what that means in terms of a continuity of care, and how we will compensate and honor those patients. So we do a training from front door to the back office, and then also the call center. So if the patient calls and uses a word, for instance, puts the word, which it has not been defined by law as this, but sometimes someone might use the word physician-assisted suicide, it's been ruled that it's not a suicide, that it is aid in dying, that these patients are dying, and it doesn't fit the psychological association's criteria for a suicide. But if they happen to do that, we want to make sure that we get it, that we're not missing a true call, and that this is someone who just wants information or whatever. So we've also training our calls to ask key questions and get the person to triage so that we can be responsible in that way as well. So we've done trainings from the very front office to the back office and also our call center to try and make sure that everyone adapts into this new law that is has some different language associated with it, and as Dr. Mahdi talked about earlier, that people may have changing opinions about over time and discomfort about, yet our patients may have different viewpoints than we have, and we want to make sure that at the end of their life that we're attentive to them and thoughtful about how we handle them without leaning away with our discomfort, that we lean in.
This is Leah, and staff training seems very wise. I definitely support that, but just wanted to note that much of the counseling that's required in this law cannot be delegated to staff. So the conversations, the process that we described in this webinar has to happen between the attending physician and the consulting physician and the patient.
And Leah, since you, sorry, go ahead.
No, go ahead.
Well, I was going to say, since this was mentioned, to maybe talk a little bit about the documentation required, because if it can't be delegated, it should be at least documented, I think. But I'd defer to Leah.
Not sure I totally understand the question, so.
Just, I guess, what exactly needs to be documented by the physician who's going over these options? Do they have to document what other options they offered or didn't offer? And if the patient accepted or didn't accept it?
I mean, my recommendation here would be to document all of the conversations that you have with the patient in your process here. As onerous as that is, but all that is required by the law is that the physician document the oral and written requests, the diagnosis and prognosis, the determination of capacity to make medical decisions, and the determination that the patient is acting voluntarily and has made an informed decision. Any mental health specialist assessments, you must document that you've offered the patient to withdraw or rescind his or her request at the time of the second oral request, and then a note by the attending indicating that all requirements have been met, and a notation about the drug prescribed. So that's in one of the slides. That's what's required by the law, but I think it makes sense to document all of these conversations that you're having with the patient.
And as I mentioned, I believe that the right thing to do is to template it so that you don't ever miss it. It can be in checklist form, it could be in smart text form, or in smart set form if you're on Epic. It can be in any number of ways so that you don't miss those elements to those visits, because this will be audited carefully. And it includes, by the way, if you're the request came to you, you still will want to document it, because it still counts as a request whether or not you're a prescribing physician. And that's your compliance with the laws, to document the request. Whether or not you're going to continue, that it needs to be to be in compliance with the law. That's your patient's right. And so that to document that and move them on in any way, whatever way will happen next. But it does need to be documented for that person's under the law for that person. That's been clarified for us at Stanford. So I encourage people to find a way to template. Maybe we'll be able to post something on our website at CAFP to help people see what does that actually look like. What does adequate documentation look like, or what might a model documentation look like?
Mm-hmm. All right, I think we're just out of time for questions. If there are any last minute ones coming in, I'm happy to email it out to our speakers and respond back to you. But in the interim, thank you everybody for attending this webinar on the End of Life Option Act and what you need to know by June 9th. If you have any questions, feel free to email me, and I will be emailing out the slides with a couple of links to some of the mentioned documents that are required. All right, thank you. Have a great day, everybody.
Thank you.
Bye-bye.
Thank you.